Hello, this is Dr. Azizian. Welcome back. Today's topic is extremely dear to my heart, and I have to say that I am very excited because it's one of my soapboxes. And I know we all have them, and of course I have many of them, but this topic about penicillin, overdiagnosis of penicillin allergies, is something that I can talk about a lot. It's something that I see in my clinical practice all the time, and like I said, it is a soapbox. So today I allow myself to indulge myself in this. So we will be looking into a new recommendation. It's actually written by Dr. Nina Mörsch, and it's this article is called Misdiagnosed Penicillin Allergy, New Recommendation. So here we will be discussing what is happening in today's world, today's culture, where many patients, or a high percentage of patients, claims to have penicillin allergy, while in reality they don't. And of course, now you guess why is it a very triggering topic for me, because often as a surgeon and as a physician who treats a lot of infections, I do need to think about which antibiotic to offer to the patient. And hearing that, oh, I think that I'm allergic to penicillin because at the age of 2 I vomited, and I hear this from an 80-year-old man, for example. It's hard to know what to do with that. I usually recommend to patients in general to have a formal allergy testing because it is helpful. It's not 100% accurate, but at least it is helpful, especially after a certain age, let's say an age of 40 or 50, when unfortunately there is a higher likelihood of ending up in the hospital with an infection and requiring emergent antibiotics for whatever reason. It could be a general body sepsis from a minor wound infection after a hot tub on vacation, for example. It could be encephalitis of some kind. It could be a colitis, something that I see more often. And it's just very inconvenient, sad, and also debilitating, I think, both for the physician, for the provider, and for the patient, when you can't prescribe the correct antibiotic because patient has alleged allergy. So, well, I try to be open-minded. However, very often in conversation with the patient, I do again and again realize that what they are communicating is not a true allergy. So, but let's look at this new recommendation. So this is Professor Norma Jung, what's called Jung, from Germany. And she is talking about this initiative that's called Choosing Wisely when assessing suspected penicillin allergies. So she first gives a scenario, which is a common scenario, of a 55-year-old patient who comes to the emergency room with a fever and swollen, warm joint. And then they remember that they experienced diarrhea and nausea after taking amoxicillin, which is a kind of, which is a penicillin, 10 to 15 years ago. And then patients' labs come back and they all show infection, and their infection, they do have a blood infection with Staph aureus bacterium, and that bacteria is very common and it responds very well to penicillin, a sort of garden variety Staph aureus. And now Dr. Jung asks the audience, what would you do? So very good question. So now here she proposes choosing wisely recommendation. So the statistics is that 5 to 10 percent of population claims to have penicillin allergy. I actually think that it's much higher. My personal intake data probably would show 20% at least. I think 20%, although we never did a dedicated statistical study, but I can say that from the patients that I encounter and treat, my guess would be 20%. I could be wrong, but she cites that people who claim, so we don't know if they have an allergy or not, but they claim to have penicillin allergy, 5 to 10%. So, but then the literature that she quotes, she states that indicates only 1% of population actually has a true beta-lactam allergy. Beta-lactam is the structural core of penicillin. So 1% of population has a real allergy to penicillin. So, but yet, of course, this it's documented from what patient is saying. And what happens very often, because patient is allergic to penicillin, which is a first line antibiotic, they end up getting much more sophisticated, or as we call them, second line antibiotics. And the problem with second line antibiotics is that they sometimes are much more wider in their coverage, which is again detrimental to our gut. And we've discussed this on this channel, how our gut microbiome suffers from especially unnecessary and sometimes even necessary use of antibiotics. So we should use antibiotics only when we truly need to use antibiotics. So now we're basically going from a first line antibiotic, which is penicillin, or penicillin derivatives such as amoxicillin, for example, is a first line. So, and we go to a fancier and secondary antibiotics, and that is not good for our gut. That is not good for our health in general, because it leads to resistance. And the other point that she makes is that, again, I see this all the time. I totally agree. I'm with her on that. Is that people call the side effects of antibiotics as allergies. So, for example, diarrhea and nausea, or GI upset, though it's not an allergy, it's a side effect. And that side effect could vary. For example, in one derivative of penicillin, one derivative penicillin can cause those side effects, and the other one would not. So that's why you don't want to obliterate the whole class of antibiotics because you had more prominent side effects. And yet I agree with her on that, but also I have to say that conversation with the patient, clinical assessment, and history taking is very important, because sometimes patients say that they said, oh, I took this penicillin, for example. I took penicillin for my tooth and it was horrible. I was going to the bathroom all the time, having diarrhea. I became dehydrated, etc., etc. I listened to the patient. I would not prescribe the same medication that caused this. Like, I wouldn't prescribe exactly the same penicillin. I would say, well, it sounds like you had a bad side effect, which is a known side effect of this antibiotic. Would you like to try another medication from this family? And obviously not the same medication. So it's very important not to ever force the patient to take medication that made them feel so miserable. So I would add to her statement, because she basically does state that we need to, as medical providers, we need to differentiate from allergies to side effects in how we explain that to the patient. And that's very, very true. And I definitely agree with that. I just think that patient needs to be involved and understand what is behind this decision making, and that's part of why I'm reviewing this article today. So and then she proposes this what she calls a PenFast score, and basically it looks at a few things. One of them is 5 or fewer years since response So that's important, of course, because again, if somebody says that they had something happened, a lot of times people don't know. They say, oh, my mother told me not to ever take penicillin. So if it's been 50 years, 60 years, or whatever years, many years, that of course has less weight than compare if it just happened just recently. So they're using 5 years as a cutoff. Then if you had anaphylaxis or angioedema, and angioedema of course is a swelling, and I would add with angioedema probably anasarca, which is a full body swelling. And of course, yes, if the patient had these symptoms, then yes, those are severe symptoms, and they should never have that antibiotic. And the reaction is treated. That is also very important to know. So I think that that's a very good tool to assess on what to do with these patients who claim to have antibiotic allergy. I also have some patients that state something like, for example, I am allergic to penicillin, and I would say, what is the reaction to penicillin? And they would say, oh, no, I don't take it. Is my mom, or I don't know, my uncle or somebody was allergic, and that's why I think I am probably allergic too. So that happens too, that people just assume that they're allergic to penicillin based on the allergy of their relatives. And that, of course, is it possible? Of course it's possible. We do talk a lot about genetics here, and genetic intolerance and allergy to a certain medication is definitely a possibility. However, we can't just assume that. It's not a common event. It's actually a quite rare event. So I do not think that that's a valid way of just sort of attributing an allergy of your family to yourself. So I always tell patients that we will not document it as an allergy, because that's not their family history. We're only asking about allergy in this setting. So, and if they have not had an allergy to certain medication, or if they never had that medication, then by definition they are not allergic to their knowledge, because that's what they ask me. Are you allergic to any medications to your knowledge? So so that, of course, sort of a funny thing, and that's not that common, but I periodically see that with people appropriating their family allergies. So, but I am very happy about this, because I sometimes felt like I was one of a few clinicians who just got triggered by this. But this is very nice. I'm glad that this is being communicated. One more point I wanted to make, that I saw it here. Yes, so what it said that when using a regular beta-lactam stands for more basic penicillin type medication, compared with the usage of more sophisticated and high level vancomycin, they noticed that mortality was actually decreased when you use penicillin. And that makes sense too. The higher you go with more sophisticated antibiotics, especially if you don't need them, you cause lots of side problems in your body, side effects now that do have sometimes lasting effects, because remember, a lot of these antibiotics are used on people who already have an infection. Their system is already compromised. They already have full body, or at least most of their body, most of the systems are inflamed, and now you are giving them something that's causing side effects. And based on that, I think that it's to everybody's benefits to find out exactly what you're allergic to. If it's possible for you to see an allergist and just at least work on it to see if you're allergic, that's very, very helpful. It is not 100% determination, but it is very helpful. And just remember, we all could end up in the emergency room like this patient that was described, and basically the solution to our problem would be your basic penicillin, and to use something that has been around for a long time, something that's quite precise, works well, and well studied is much better than using more chemicalized and more advanced second line antibiotics that bring all kinds of new side effects, and some of them that are not so great, so, and some of them not well studied, unfortunately. So great article, so I'm happy that this is being talked to, and thank you very much for listening. If you enjoyed this video, please like, subscribe, share. Thank you, and until next time, bye bye.